Well, I just wanted to say thank you, everyone. I know as someone with two little kids, I'm in Cincinnati, Ohio, and we're still on East Coast time, so it's 8 o'clock here. It's Tubby time, it's bedtime. So I just wanted to say thank you for everyone for being on and then taking time out of your week just to do something and learn something and hopefully just kind of to add something new to your practice. Um, this first slide, this is just something I do a lot. I call them my little pediatric dental buildups with my pulpotomies, and then using a bioceramic NeoPUTTY MTA, and then building up these teeth with a high viscosity glass ionomer cement and either prepping zirconia crowns or stainless steel crowns. So there's a lot you can do, I think, with bioceramics with really broken down teeth, and then building them back up with some type of high viscosity glass ionomer that's not going to have polymerization shrinkage. So just a disclosure, New Smile does help financial support for putting on these presentations. And for the training materials for pediatric dentistry. And a lot of the images, if it's not my image, it's some of my other fellow colleagues as well, and I do put that out there. Just thank you to the team at New Smile for just kind of for those of you guys. Hopefully, you were at AAPD and able to check out the booth. I think one thing that I really like about using products from this company is everyone is super supportive and really wants you to be successful with their products, whether it's the bioceramics or zirconia crowns or stainless steel crowns or some of the new preventative products. A lot of the staff here, everyone just wants you to be successful in your office, whether that's support with the product. If there's a problem that you guys have with the product, always reach out. They're always trying to improve and making sure that they're providing just high quality pediatric dentistry materials. This is me in my little wild slide. I have two dogs, Waffles and Maple Syrup. I have a 4-year-old and a 2-year-old, so our house is nuts at all times. I work at Cincinnati Children's Hospital, and then I work in private office a day a week. My background was working in the National Health Service Corps as a pediatric dentist out in Navajo Nation, and then I also worked in Western Carolina. I was just down there this weekend with the Eastern Band Cherokee Indians. So that's Cincinnati Children's Hospital. It's a big place. We make up the dental clinic's like right back there somewhere. So we're a very decent little footprint in an otherwise large hospital institution. And then this is the private office that I work at as well. So I get to happily live in both worlds, which I think is amazing, working with the residents at the hospital most of the time and then working in private office. So why are we all here tonight? We're trying to learn something new or incorporate something new into our practice. And these are from Peloton. I'm not that smart to come up with cool things like this. Do things that you don't like to do. I do a lot of endo and a lot of surgical stuff, and this is kind of what pushed me to do some more of these things is figure out what you're uncomfortable with. What are we changing, or what can we incorporate into our practice that, we've been doing this one thing for 20 or 30 years and it's been working, but what else is new? What's the latest and greatest in general dentistry, pediatric dentistry that we can incorporate into our office that's going to push us and make us feel a little uncomfortable, and at the end of the day, hopefully make us a better provider and provide better care for our patient population. So this is my son, Winston. I like to show this video. This is him trying, I call it like little kid CrossFit. This is him trying this. Wasn't really good at it now. Now he's pretty good. And he's just crawling along that wall, and I'm not being the best at him. Boom! He just kind of smacks his head into the wall. So this poor little guy, man. So he did that twice that day, but now Winston's a pro at Kid Strong. He's awesome at it. So sometimes we just have to try new things, and we're not really great at it. When I teach the residents zirconia crowns, I've made every mistake you can make with a lot of these products and things. And it's just learning from those experiences and getting better and educating yourself. Who are you still learning from? The team at New Smile and the docs that work with them, I've learned something from every one of these people. I always am on, if it's Wednesday, it's learning time. So a lot of Wednesday night while we're, bathing our kids, I have an earbud in and I'm listening while my kids are screaming to what Paul's saying or Laurie Johnson saying, or, or Ann, and I just always pick a little kernel up. So I learn from all of these people. Who are your mentors? Who are you learning from? I think that's a big thing in our community practice, whether you're on IPEDO looking at cases people are posting or having discussions in your own community. So one thing that I like to say, and why I like kind of working with New Smile is we're slowly kind of turning into this one-stop shop, this supplier for pediatric dental supplies. I like to call New Smile. They are the leading supplier of pediatric dental solutions because they're coming out with products that are specifically catered to pediatric dentists to help us do our job better and be more efficient. So just an overview, one thing that I like to point out, I have some QR codes in here. New Smile has a lot of these webinars recorded that are online, so really check them out. They're pretty rad. I always say, hey, go check that out on YouTube and things like that. So we're gonna go over bioceramics, NeoPUTTY, NeoLiner, two bioceramic materials, and we're gonna talk about how the pulp. And for those of you guys that are AAPD, I did a lecture on apexogenesis and apexification on adult permanent teeth, and how these products can really help relate to the inflammatory process that we are trying to fix when we do a pulpotomy or a direct pulp cap or a partial pulpotomy, and examine how that inflammatory immune response dictates what kind of bioactive materials that we need to be successful. And then we'll talk about these clinical uses. I try to have a ton of clinical, uses and clinical pictures, because that's what we're really here for. We want to see how these things are being used in the real world. So we're going to talk about inflammation, and we're going to talk about how inflammation relates to our choice of bioceramic material. And then we're also going to talk about the difference between calcium hydroxide and a calcium silicate-based material, or an MTA. And we're going to talk about clinical indications for those, and also resin-reinforced calcium silicates. So let's kind of get right into it. It's a lot of information to cover in an hour, and I want to make sure I have time for all of your guys' questions. I have my email at the end if anyone has questions or has, cases they want to share with me or anything like that. I'd be more than happy to talk to y'all about it. So MTA-based liners and pulp therapies. So an MTA modified liner, think about your Neo liners, your Theracals, your Limelights. So there's going to be things when we're close to the pulp, where there's an area of inflammation, the pulp is not exposed, and we're trying to put, our baseline, or if for those of us who have been practicing for a longer time, your dical Vitribon, in those areas that we're trying to get some calcium release or protect the pulp from etching on top of it and maybe putting Vitribon down. Well, this is a product that's kind of all in one with the NeoLiner. And then we're going to look at an MTA putty or a ditricalcium silicate. MTA is just kind of this catch-all phrase like Kleenex or Pepsi, that we're talking about hydrated calcium silicates that you can place directly on the pulp for permanent tooth apexogenesis or pulpotomy, direct pulp capping. We're doing so many more direct pulp caps on permanent teeth that are being successful. You're saving a lot of these teenagers who have severe caries in the maxillary anterior and in the posterior from needing root canal therapy on these anterior teeth by doing these very planned direct pulp caps. So I kind of got into this topic, pulp therapy and pulp, when I started working back at Cincinnati Children's, and I noticed like, man, we're not doing pulpotomies anymore as much as we used to. So I did like a retrospective evaluation with some of my colleagues from when we first started keeping online data from 2008. And the blue line is indirect pulp therapy, and the orange line is pulpotomy. And you can kind of see there's been this almost switching, especially around 2014 or 2015. And then that downtrend is when COVID started, and of this trend of indirect pulp therapies totally taking over. And I think part of that is we have a better diagnosis, and we're better clinicians as far as understanding when and how much caries you can leave, and also understanding the inflammatory process of a reversible or irreversible pulpitis. But I also think we just have better materials now. I still remember when I graduated from residency, ProRoot was kind of like, hey, we have this little packet, and maybe we'll do pulpotomies with it one day. And I think now I would say a lot of the majority of providers are using calcium silicates. So this is Jim Cole and Vineet Deer study out in Maryland, and they actually just published another in the more recent AAP journal that also looks at permanent pulpotomies. And this is all very evidence supported. And when they look at, they have this really great flow chart, which is why I like to show this, is now, and through the course of our education, formicreosol was the gold standard for pulpotomies. And then in the next iteration, it was like, well, formicreosol and MTA are pretty similar. And now the research really shows that your di or tricalcium silicates, your MTAs, your biodentines, your NeoPUTTYs, those are all superior to formicreosol as far as vital pulp therapies. And then just kind of a discussion that we're going to hop into now and try to really thread this needle of inflammation and how our choice for a material helps support that process of reparative dentin. So we all kind of know about infected and affected dentin. As we go through this dentinal tubule, we have some contaminated area, and then we have a area of sound dentin, and then tertiary dentin that's reparative dentin or regenerative dentin. So the question is inflammation a prerequisite for pulpal healing? And I would say yes. What's really wild when we look at pulp and inflammation is that it's an immunological response. We locally have immune cells that can recruit odontoblasts to differentiate and make that reparative dentin. And in more deeper areas of decay, like severe trauma or something that leads to a pulpotomy, we can actually recruit cells down from the root areas, and they can differentiate into odontoblast-like cells. So it's pretty wild that this is all mediated by immune cells that are residing within the pulp. So when we think about when we're doing a pulpotomy, this is an immunological response to inflammation. It's kind of wild and blows your mind when you think about it. So we have kind of two different routes that we think about, a mild stimulus or an intense stimulus. When I think of a mild stimulus, I'm thinking something as like an indirect where that caries is really deep, but maybe the patient is having some cold sensitivity or things like that. So we have this reactive dentinogenesis, and then we have our more intense stimuli where the pulp is grossly exposed, or we have a large carious pulp exposure where we have to do a pulpotomy, and that's going to recruit dental pulp stem cells that will then differentiate into odontoplasts to help form that reparative dentin. So pretty wild when we think about these things. So let's talk about reactionary dentin. This is going to be our subtle stimuli. So minor trauma, operative procedures, reactionary dentin is formed with our viable odontoblasts that are just kind of hanging out in that area. So this looks pretty similar to regular dentin. And the way I like to think about this, and I have some clinical examples, is we have this large lesion, that big occlusal with molar hypomineralization on number 3, or just a large carious lesion that makes I call them BACs, big awesome cavities, but the A stands for something else. And that caries, and you're taking it out and you're just praying to all the dental gods that you're not going to be in the pulp, but you end up with this really nice leathery sound dentin, and on the x-ray, there's a good amount of differentiation from the pulp tissue and from the amount of dentin that you have. Well, that's when we're maybe just putting down our neo liner or something that's still going to release ditricalcium silicates, but also not really needing a pure MTA product because we're not as close to the pulp. And then now we have our reparative dentin. So this is where our odontoblasts are more severely affected, an invasive carious lesion that's going into the pulp. Maybe we have a larger carious pulp exposure where we actually have to go in and take out some of that pulp tissue. So this is where these cells get differentiated and recruited down deeper from the pulp tissues of the root, and they morphodifferentiate into odontoblastic-like cells. So this material is less organized. It doesn't really look like dentin. And this is just kind of a schematic process showing that as we get, it's kind of like if you think about featherstones, caries, imbalance, it's kind of the same thing, but like now this is the pulpal imbalance, where we have these infective byproducts that are putting more stress onto these cells, and we go into an area of imbalance of pulpal regeneration. And if this gets so severe, then you lead to pulpal necrosis. But we're talking about areas where the pulp can still be repaired. And what really blows my mind, and I can send textbooks on pulp therapy if you guys are interested in the pulp, is that you have all these inflammation markers that are involved in irreversible pulpitis. So it kind of blows your mind that this is a heavily inflammatory and immunological response. I never really understood this stuff. I always thought dentistry, like I don't understand my cell phone. Like, this is magic. I just pull up YouTube and a video comes up. And then sometimes in dentistry, we just don't think about this stuff. We're like, oh yeah, I poop this into the tooth and it fixes the pulp. So it's just kind of cool. We're like, hey, let's talk about how this stuff actually works. And I think it kind of blows your mind. So this is a great article that's going to lead us into the discussion about what materials we're going to pick and what physical properties are better or more ideal in a bioactive material. So, you have your tried and true stuff that we use forever, DiCal. These are calcium hydroxide based materials. If you guys ever use Limelight, which is a resin modified calcium hydroxide material. So calcium hydroxide, I would say you can just toss that out. And we'll kind of talk about that in a second. MTA or ditricalcium silicates are superior to calcium hydroxide-based materials. So if you're using dical or limelight, you can eat it, throw it in the trash. You don't need to use it anymore. There's better materials out there that you're going to get better outcomes with. And we'll talk about that in a second. And then you have your bioceramic-based materials. If you are choosing, now that you have pure di and tricalcium silicates, like your NeoPUTTY, biodentine, any type of thing that doesn't have resin in it. Now, the biggest thing when you're picking out an MTA product is you have to make sure it doesn't have bismuth oxide in it. That's a radio opaquer. And what it does is it actually causes darkening. And when I used to use ProRoot and we would do these apexogenesis on these kids, these teeth would look black. So when you're doing something, a product like NeoPUTTY, it doesn't have bismuth oxide. It will not stain. A lot of them now have zirconium oxide or tantalum, and it's actually a non-staining radio opaquer. And then when we start adding resin to things like your Theracal LC, your Neoline, or your Ceram LC Protect, that's when we have to talk about, well, can you use that in the pulp or not? How close to the pulp can you get? And we'll talk about that as well. So some of the things we want to look at in a property is the pH, how alkaline is it? What's the alkalinity change in that material? So is it alkaline and does it stay alkaline? So when you're looking at this study and you look at some of these products, some of the more pure MTAs are going to be highly alkalized and stay alkalized, whereas some of these other things like limelight that have more resin in there, the alkalinity is lower. And we're going to talk about calcium release as well. And then you're also going to look at the degree of water absorption and water solubility. One of the biggest issues with calcium hydroxide is it doesn't really stay well within the tooth. Over time, you get these little tunnels due to the contamination of moisture. And then even if you did a really sound restoration, you're going to get voids in it from that calcium hydroxide going out. And then the other thing we're going to look at is the cumulative calcium ion release and how is that important to the pulp tissue. So this is just a study that also, a similar study, or it's the same study, excuse me, that looked at the degree of calcium release. So you're going to find your more pure materials like NeoPUTTY, biodentine, MTA Angelus, so nothing with resin in it has the highest degree of calcium release. Whereas once you start contaminating things, if you look at this lower line right here, Theracal LC, and then isn't in, or limelight isn't even really charting that high on the level. So once you start adding resin to it, its degree of calcium release is being decreased. So our indications for pulp therapy, so we're talking about vital pulp therapy, is a tooth that has reversible pulpitis, so it's relatively symptom free. So we're not talking about a necrotic tooth or something that has excessive inflammation. And we'll talk about that, what that looks like. Like, what does excessive inflammation mean? And then I feel like these two diagnoses are really blurred now. What's the difference between an indirect pulp cap? So we're trying to leave a little bit of affected dentin and then putting a biological material to help avoid exposing the pulp. Well, what's a protective liner when the caries is all gone, but we're also trying to place a protective liner to not expose the pulp? So in my mind, these two things are kind of blurred. And what does bioactivity even mean? That's such a hot, sexy word in dentistry right now, biomimetic, bioactive. All bioactive means to be defined as an actual material is that it has to have the in vivo formation in the tooth of calcium phosphate. So something that is similar to hydroxyapatite on the surface layer of that biomaterial. So that material that we're putting in, that the NeoPUTTY or MTA-like material has to be able to form that for it to be classified as a bioactive material. So what do we need? So let's think about what we talked about earlier. Why is the degree of calcium release important? Well, the calcium ions enhance that pulpal cell proliferation and differentiation, and it's essential for hard tissue mineralization. Remember when we talked about tertiary dentin and then the reparative or reactionary dentin? So the calcium release actually helps with that pulp cell proliferation. Well, okay, calcium is important. What about that degree of release? So the degree of release is dose-dependent effect on human dental pulp cell proliferation. So some of that more pure MTA material that doesn't have resin in it has a higher degree of calcium release. So that's going to help the differentiation of those dental pulp cells. Well, what about the alkalinity of the material? So we talked about calcium, now we're talking about the alkalinity. Well, not only is it antibacterial, but it also helps enhance the formation of tertiary dentin. and it's going to help to release tissue growth factors and other things that are important. So again, this is all tying back to that reaction and reparative dentin that we talked about. So the degree of calcium release, the alkalinity of the material, and then also the water absorption and the solubility of that material. You want it to kind of stick around. So ideal water absorption is essential for ion release, but if it's excessive, it's soluble, you're going to get voids underneath in your restoration. And that's what calcium hydroxide gives you, is you get those little tunnel voids afterwards. And over time, that can affect your restoration. So MTA, or calcium hydroxide. So we're talking about DiCal, Limelight, those products that are calcium hydroxide based versus your NeoLiner, your NeoPUTTY, your di and tricalcium silicates. So calcium hydroxide has insufficient adherence to dentinal walls. That's why it gets those tunneling defects, where MTA has a more ideal sealing ability. And that results from its higher level of calcium release. And it reacts with phosphates in the tissues to induce hydroxyapatite formation. So that's why it's a bioactive material. And you get a better chemical seal in the MTA of the dentinal walls versus calcium hydroxide. MTA is also less toxic to the pulp. So when you think about calcium hydroxide and MTA, as we're placing it down, your MTA is less cytotoxic to those pulpal cells. So your pulp capping procedures are going to have less overall pulpal inflammation compared to calcium hydroxide. And then the application of MTA has a direct effect upon the regenerative potential, just like we talked about, the calcium, the ion release, things like that. And that's associated with an increase in tissue growth factor that's secreted from the pulp cells. So it's going to help. So kind of like that MTA is winning, it's beating that calcium hydroxide in the area of sealing ability. It's how it likes pulpal cells and its ability to regenerate pulpal cells better than calcium hydroxide. So that factor that we talked about, the tissue growth factor, this factor directs the cell migration. Remember how we talked about those cells can differentiate into odontoblastic-like cells? Well, that factor helps those things come up to that interface and stimulates their differentiation into the odontoblastic-like cells. So now we're kind of threading that needle that we talked about earlier. So MTA is superior to calcium hydroxide in all of the things that are going to help us make the pulp healthy. So our protective liner, we kind of talked about the objectives. It kind of morphs a little bit and gets a little blurred when we talk about what's a protective liner and what's an indirect pulp therapy. And we're going to show some cases that'll look at that too. So the first thing we're going to look at is our NeoLiner. So these are indirect pulp capping and using it as a cavity liner. When we want to prevent sensitivity, if we're etching over this area, and we want to avoid excessively opening those dentinal tubules that could possibly access pulp tissue causing inflammation, and also get the benefit of some calcium release. Or we want to place it over that high mesial pulp horn that we didn't expose and it's not blushing, but we also don't want to etch over this area where we're leaving a little bit of decay, and we're protecting that as well, that affected dentin, not the infected softer dentin. So this is not exposed pulp tissue. So when you look at some of the competitors as far as indication for use, again, as a cavity liner for indirect pulp capping, TheraCal, there is in the IFUs that they say you can use it for direct pulp capping, and we'll talk about that in a second. But looking at the degree of calcium release, remember we talked about that earlier. Why is the degree of calcium release important? Because it helps relate to the reparative dentin formation. And NeoLiner, when compared to TheraCal LC, does have a higher degree of calcium release. And when you look at the pulp and the exposure, so direct pulp exposure, TheraCal LC was found to be more cytotoxic to those cells, and that's because there's resin in there. Pulp cells do not like resin. Anything that has a BisGMA or some type of acrylic monomer is not going to do well on vital pulp tissue. One, if it's not totally if it doesn't totally get set, or if it's exposed to vital pulp tissue, there's going to be some layer of cytotoxicity to that. So I would avoid using anything with resin in it directly on pulpal cells. So these are going to be for indirect only. So what are the benefits of NeoLiner? It does command cure. I really like this. You can just throw away your DiCal and Vitribond because it's so easy to place. You can just put it on there and cure it. It has a high degree of calcium release, and this is an MTA product. It's a di and tricalcium silicate. So it's promoting all the things that we just talked about that MTA helps do. Hydroxyapatite formation, alkaline pH, higher degree of calcium release. So it's going to help protect against hypersensitivity because we're going to cover those areas where the pulp tissue is closer to that higher mesial pulp horn or that pulpal floor that we don't want to etch over. It's insoluble and moisture tolerant. Those are the benefits of the MTA. And you can etch bond directly over it. It's radio opaque and easy to see. So here's a case. This is a primary canine. And if you can kind of see in this area, this is a little area of some possible tertiary dentin formation that already occurred. So my pulp can be probably really close here. And the thing I really like about NeoLiner is it goes exactly where you want it to. If you really want it in a small area like this, you're going to use the 22 gauge sealant tips that it comes with. If you have a wider area, then you're going to use like an etch tip, and I'll show you guys that as well. So again, you can put this NeoLiner, just make sure the area is fairly clean, right over that tooth, and then you're going to etch bond restore right over that. So that's what I really like about this product. It just goes right on there. It would be really hard for me to do with Vitrabond. Here is another case. I'm replacing this amalgam. And here is kind of a few pictures where the amalgam is removed. So this is a case where I'm probably going to cover this floor because I'm worried about etching directly over that. If you guys can kind of see that pulp horn's pretty high, that distal pulp horn. So after I remove my amalgam, I'm going to put a layer of NeoLiner over here. I'm not in the pulp, but I'm using this as a base liner. So here's my prep cleaned out, isolated. Here's my layer of NeoLiner. If you're using more, then I'll just use an etch tip, and then I'm going to restore directly over that. Etch, bond, restore. That's why I really like it. Here's another case, large carious lesion here. These are when this patient comes in, your cheeks get really tight and you're like, this is not going to be a fun day. So here's partial caries removal. You can kind of see a little bit of affected, infected dentin left. And then I have my prep cleaned out. So this is, again, that first case I was using it as a liner. Here you can definitely see I'm leaving some decay behind. So this is that leathery affected dentin. And then I'm placing my NeoLiner. I love this stuff because it just goes right where you want it to go. It's not sloppy. It's really easy. I'm making sure I have clean margins. And then here's my final restoration afterwards. And then here's another case. I really like this because I'm combining, I call it the Paul Bond band technique. This is something I learned from Paul. It's also called the Palmetto technique. Palmetto, sorry if any of y'all are from South Carolina, I apologize. So you can kind of see we removed the decay, but we still have this leathery affected area, and I'm trying to protect this pulp horn. And so we place our NeoLiner down over this area, and then we have our orthodontic or a smooth band that we've already cemented. The reason why I like to use these smooth bands is that it maintains the occlusal relationship of the tooth. So I'm not using a Tafelmeyer or a band that's going to fold over. I'm maintaining that occlusal table, cementing that, and then filling this up with either a resin modified glass ionomer or doing a closed sandwich technique where I do a resin modified or pure GI and then putting a composite on top of it. So you can just etch bond restore on top of this. That's another reason why I really like it. This is Dr. Lucero's case. I think this just really highlights how you can get perfectly isolated and place that NeoLiner right where it needs to go. I love this small sealant tip, especially for anterior teeth. And he does duration over there that you can just put it directly where it needs to go. You're not worried about being messy or having it going over your margin or a bubble over your margin. I really like NeoLiner in these instances. And then this is another Dr. Lucero case just showing how the material is radio opaque, which is what I really like. And you can see Dr. Lucero probably has a flowable tip here now. Needs a little bit more material, gonna grab a flowable. And then the IFU for this, you want the NeoLiner to be only 1 millimeter thick. How much do I need to use? Just 1 millimeter. So that's why in most instances that sealant tip's going to work. And those adult molars that I had utilized, that's why I pulled out the etching or the flowable tip. So now we're going to talk about vital pulpotomy. This is just a QR code. I have a goofy YouTube channel, but this is a video of me doing a pulpotomy, an MTA pulpotomy. Since we only have an hour, I try to put little videos of me doing things. I have another pulpotomy video too that you guys, if you're curious about actually seeing the full pulpotomy. So when we do a vital pulpotomy, that is when we have a mechanical or carious pulp exposure. We want the pulp to be vital. Again, we want to be in the absence of spontaneous pain, so it wants to be a reversible pulpitis, not an irreversible pulpitis. And we should be able to get hemostasis just with the cotton pellet. You don't want any apical or focal radiolucencies that are showing some type of infection, and you want to be in the absence of swelling abscess or fistula, because that would mean the tooth is necrotic. And then we want it to be restorable. Sometimes I push those boundaries, but I always like to do these buildups, and you'll see that a few times. So what is a hydrotic calcium silicate? What is MTA? So MTA again is like the Coke and Pepsi Kleenex word, but the actual term that we should be using is hydrotic calcium silicate. So it's a reparative cement, and what happens is you have ditricalcium silicate, you add water, and then chemistry happens, and then you get a calcium silicate hydrate, and then one of your byproducts is actually calcium hydroxide. So I like to think of it as you have that calcium silicate hydrate that's kind of help sealing and protecting, but we're also getting the degree of calcium through calcium hydroxide as the byproduct. So it's pretty cool. And this is what happens when it comes in contact with water. And we like this because it is alkaline and has a high release of calcium ions, and it helps seal very well chemically. So here's just another video of me actually doing it. And one thing I really want to highlight on this is the NeoPUTTY dispensing guide. So what I'm kind of showing here is me taking out the cotton pellets. And I think in this first one, I'm showing that there is a little bit too much bleeding. So I purposely tried to show, if you can kind of see, I have a large amount of pulp still kind of hanging in those areas. And you're going to see the blood start filling up. So what I'm always going to do is I usually take my access with like a 4 slow speed round burr. Well, now I'm going to go in with like a 2 slow speed round burr, take out more of that pulp tissue actually in the orifices of the ear. So I'm using any tissue tags or anything in the coronal pulp. And then I'll show another video, and I'm just using dry cotton pellets. If you look at the guidelines, you don't have to do sodium hypochlorite or calcium hydroxide. Or chlorhexidine. I just use dry pellets. And then this is actually using the NeoPUTTY dispensing guide. It actually has these little lines, which I think are really helpful for your staff. The hardest thing with this in your staff or any MTA-based product, is them wasting it. So this is really helpful. We're using that first primary molar guide. And then we're going to take our cotton pellets out, and then we're going to look at the hemostasis of this. So this is my second time doing this. And you're going to see now that heme's just pulling really nicely in those molar teeth, but it's not filling up. And that's totally fine. You're allowed to have the pulling of the heme in that area. So then we're going to put in our NeoPUTTY, and then you can use a moist cotton pellet and then a dry cotton pellet inside the chamber over there. And then I usually use either a high viscosity glass liner cement like GC Equia Forte, or we're going to place, this is just a double pump of that Vitrabond. I also have used IonoSeal is a nice product. It's a resin modified glass ionomer that comes in a tube. So it just depends on what you like to use in your office. They're all nice products. You can pretty much place anything over MTA. There's actually a research study where they looked at doing that. So if you guys want to use ZOE, if you want to use Tempet, if you want to use Flowable or Composite, just be mindful if it's a high resin product that you're not having it leak and you're polymerizing it all the way. So you have to be mindful of that you're not trying to over polymerize something that can't polymerize to that depth. So we just use a double hit of Vitrabond or Equia Forte or IonoSeal. It just depends on how much I'm using. So this is what I was trying to show again with the dispensing guide. I usually just take a little bit and roll it on the back of my hand. It just kind of helps it not be so sticky. And the dispensing guide is really helpful for your staff. If I'm just doing a little bit, I'll even just take a clean surgical spoon or spoon and scoop some out. And there is a way to be very frugal with this material. Usually your staff pushes it and like a bunch comes out, or if they have the bottles. I've had a staff member mix the whole bottle one time, and I was like, so I really like the dispensing guide. So what are our uses for NeoPUTTY? Anything where that pulp is directly exposed. This is kind of my flow with just a pulpotomy and a stainless steel crown. So occlusal reduction, access, removal of pulp tissue. I put in some cotton pellets to get good heme. Oh, I just now realizing these pictures are out of order. I apologize. There's some MTA in there. But you're putting in a cotton pellet, and then you're getting good hemostasis, putting in that measured dose of NeoPUTTY, And again, here's just a double pump of Vitribon, how it comes in that click. Refine your preparation and then put your stainless steel crowns or zirconia crowns on. So what is, when we talk about good hemostasis, this is a tooth that we ended up doing a pulpectomy on, but you can see that blood is still coming up, and we're going to suction it, and you'll be able to appreciate that better. So we're going to suction it. I just think it's really cute because it looks like it's smiling. And you see that blood just came right back up. That thing is mad. It hates its parents. It's angry. And so then now we have too much pulpal inflammation. So if I'm doing this, I'm going to think about a few things. Do I need to go deeper? Do I have tissue tags? Did I not remove enough pulp tissue? Or two, is there so much inflammation that now I have to do a pulpectomy of this tooth or some other pulpal, or an extraction? I usually kind of bend over backwards to save second primary molars if the sixes aren't erupted yet. If the sixes are in, you're gone, space maintainer, or I'll do a distal shoe. But if I have the time, I'll go and do a pulpectomy. Here's what a good hemostasis looks like. So we've done our thing. You can even see some pulp tissue left in this canal right here, but there's pooling blood, but it's not coming out. So we're okay to head ahead and restore this tooth. So here's just another little video. I know we're running out of time, so I'll make sure I get to everything. But pretty large caries in interproximal space loss between S and T. And so we're gonna over prepare one of these. Again, two things cannot occupy the same space. I use a 245 burr a lot when I'm doing back-to-back stainless steel crowns. So we're gonna have our caries removed, and then we had our caries pulp exposure and doing a vital pulpotomy. So there is our good hemostasis after we did our pulpotomy, and I'm going to isolate this friend and place a matrix. I don't always do this, but only if I really need better isolation. And make sure your margins are clean. And we're going to bond some glass ionomer in that area. So we're using GC Equia Forte here to fill it up. And you can use a double hit of Vitribon. You can use anything, but if you're using composite, just make sure that your depth of cure isn't going to have some unpolymerized resin that could potentially be cytotoxic to the cells of the pulp. And then we're going to refine our preparations after that setup. But you can use Fuji 2LC, RMGI. So we're going to redefine our preparations, make sure we have enough interproximal reduction for 2 crowns, and we're going to deliver. So another thing that blows my mind about these products is, again, kids that we were sending to the endodontist for root canals because of carious pulp exposure, we can now do partial pulpotomies and allow for continued apexogenesis of these teeth, and these patients can remain symptoms-free. Now, this patient's probably going to need a stainless steel crown or a more definitive crown later, but we still preserve that restorative margin of that tooth. And then we're doing a lot. Our office is at Cincinnati Children's. We're highly Medicaid. So we're seeing a lot of kiddos where we would have extracted a lot of these teeth. And so we're doing permanent pulpotomies on a lot of these teeth. And this is, I think, was Vineet and Jim Cole's newest article in AAPD that's in support of these pulpotomies. And what's really rad is if you look at the research on this, they're even doing these in some teeth that have irreversible pulpitis. So when would I, but you have to really be keen on the diagnosis. Is this reversible or irreversible pulpitis, and talking about the chances with the parent. So another question is, well, why don't you just take this tooth out, man? Like that 6-year molar, the 12 is still undeveloped. The parent didn't want the tooth out. And one thing that I tell people, if you're going to do this procedure, you might want to get they're surgical length slow speed burrs. They're called right angle surgical length burrs. I usually have a 4 and a 2. And they're just really helpful when you're doing these permanent pulpotomies. You can get them through any of your dental suppliers. They usually come in a 5-pack. And they just really help when you're doing this. The same technique as a regular primary molar pulpotomy. And then this is just, again, we're doing really cool stuff with this material. Here's a premolar that's pretty beat up. And this tooth actually did get a definitive crown. My wife's a general dentist, and she actually just delivered this crown. Caries was removed, and then we cleaned the area with sodium hypochlorite just to kind of get rid of, and that's a whole separate thing on why I do that, just to get rid of some of the the protein, deprotonating those areas from the bacteria, the contaminants of that tooth, and then we're placing our NeoPUTTY down, isolate and restore. So why did I use NeoPUTTY instead of NeoLiner? Well, pretty dang close to this pulp area where I'm kind of concerned for micro pulp exposures. So that's why I decided to use NeoPUTTY versus NeoLiner, just due to my proximity and how close I thought I was to the pulp tissues. And this tooth is vital. You know, it's testing vital. So these teeth where you're being a little bit more squirrely, you want to make sure that you're pretty keen on the diagnosis from the pulpal standpoint. And then we're going to do a really nice restoration buildup, and this crown just got delivered. So this is from Dr. Lucero. This is a great, it's really hard to find these great cases. A lot of times when you actually have a vital pulp exposure, it doesn't bleed. So it's really hard to get a picture. So Matt did a great job with this. The American Association of Endodontics actually has a workflow for vital pulp therapy on permanent teeth. So this is a direct pulp cap. And one thing that Dr. Lucero did a great job on, if you're doing a direct pulp cap, all the decay has to be removed. So this isn't going to be in an area where there's still affected or infected dentin. If we're doing a direct pulp cap, we have to make sure all of the caries has been removed. And then Dr. Matt is doing a partial pulpotomy here, where he's placing a sodium hypochlorite pellet. We use 3% sodium hypochlorite. Full strength post-COVID is actually like 5, 6, 7 sometimes. So we get it from Vista Apex, it's 3% sodium hypochlorite. And then you want to have this beautiful pulp tissue. If this thing's still angry and mad, or it doesn't look beautiful like that, you know, it's red, and then you're going to proceed to doing a fuller pulpotomy. And then Dr. Lucero is placing his NeoPUTTY, NeoLiner, or you can place whatever you want over it. It's just for ease of use, and restore on top of that tooth. And you want to check back and make sure that these patients are asymptomatic. This is a great case that I love showing because you never get to see the tertiary dentin bridge. This is a young friend that had fractures of 8 and 9, previously had vital pulp therapy on number 9. And what was really rad is you can see, whoa, that's the tertiary dentin formation of that tooth. And then, so that tooth was still vital right here. So what do? We're going to do another vital pulp therapy. We're going to, you know, minimally invasive endodontic care. So on this side, I just kind of cleaned this with sodium hypochlorite just because it was exposed, but I'm not messing with that tertiary dentin bridge. And then I just did a whole nother vital pulp therapy here. There's my NeoPUTTY. I had great hemostasis. I'm going to fill the teeth with a high viscosity resin cement like Juicy Equia Forte, and I'm going to do my composite over that. And you can really see where that tertiary bridge is here. And then here's our NeoPUTTY. So there's our end state. And we're kind of running out of time a little bit, but in the last few minutes, these are just fragment reattachments, and I like to use the NeoLiner for that when there's not a direct pulp exposure. And I think you get some nice results in these kiddos where the teeth might have not fully erupted yet, and or teeth that are slightly more complex, but it just gives that tooth a more natural appearance. You know, composite strip crowns work great too. I use both of them. But if the parents bring the fragment and they're well hydrated, and I'll ask them, we can do either or the kid's tooth is maybe not the shape of a composite strip crown. You can get nice outcomes with that. These are my little pups, waffle and maple syrup. And then just like to tell this story, Maple had a vital pulp therapy exposure. So he had a pulp exposure because he's crazy. He jumped out of a car, and the vet wanted to do a root canal. And I was like, well, wait a minute, let's just put some NeoPUTTY on this. So that's what we did. I did some NeoPUTTY and some high viscosity glass ionomer cement, had to repair it a few times, but eventually we got some great pulpal healing, and he still has this tooth. He just got his dental cleaning. Yeah, I needs a filling, but you know, he still has this tooth and is asymptomatic. And then also doing vital pulp therapy for anterior teeth for our zirconia crowns. Again, when you do this, it's the same thing as a posterior. You just have to make sure you're not putting the NeoPUTTY so far down into the canal of the tooth. I just take a really small amount. Here's my high viscosity glass ionomer cement, my preparation design, and then we did 2 really nice zirconia crowns over there. And then this is a case where we did multiple anterior pulpotomies. So you can use this material in a really wide array of different clinical scenarios versus having to do a pulpectomy if the tooth is still vital. In my hands, I still like doing pulpotomies. If it's necrotic and the parent still wants me to keep it, then I'll think about doing a pulpectomy. And then kind of running at the end, I really like this case a lot because it demonstrates space loss here. We have large caries on K and L. The 6-year molar hasn't erupted yet, so it's important to try to preserve the space. So remove our caries removal, and these are going to be 2 zirconia crowns. You can kind of see the deep decay there as well. But here's what our healthy pulp is going to look like, and I have a video of that. So again, we have great hemostasis. This is just with dry or moist cotton pellets. I don't put anything on there, no ferric sulfate, no sodium hypochlorite, chlorhexidine. This is just with dry pellets. I have great hemostasis. We're going to put our NeoPUTTY in, our high viscosity glass ionomer cement, refine our preparations, put our try-on crowns on. This is our final preparations here. And then we have some nice zirconia crowns that we placed over. And I'm always so crazy about getting cement on out of these things, and it blows my mind how sometimes there's still cement left over. Well, I wanted to make sure we had some time for questions. Again, this is my contact. Ask me anything. If you guys have questions about anything, cases, that'll have my my work email, my cell phone number. Feel free to ask me anything. You won't, everything's on the table. I just want to make sure if you guys are going to use this, that I want you to be successful with it. And that's all I have.
Hey, Dr. Ruck, I'm gonna hop into
Oh,
and tell it I made it finally. So
yeah. Oh, no.
thank everyone for attending. I apologize. I had a little technical difficulties here at the beginning. Nothing will get your heart racing real quick when your Wi-Fi messes up 2 minutes before the webinar. So but yeah, while y'all are having, if you have any questions, go ahead, type it in the chat. But I do want to go over again how you can receive your CE. So while I'm talking about this, if you have any questions, go ahead and type it into the chat there. But your CE, you will receive an email from our events team with a survey. Once you complete the survey and send it back, they then will reward you with the CE credit. Please give the event team usually about 24 hours to receive your survey, and then from there, like I said, they'll send you the CE via email. If you have any questions whatsoever, once again, my name is Preston Fontenot. I'm the North American Sales Manager with New Small. You can reach out to me as well. Also, feel free next week. Just wanted to bring it up. We will have another webinar on mastering zirconia with Dr. Matt Lucero. It'll be also a really great webinar to catch if you're interested in some really more in-depth tips and tricks on zirconia. But yeah, Dr. Ruck, looks like we really only have one question. I think you actually went over this. It was, do you place anything over NeoPUTTY before final restoration? So.
Yeah, that's a great question. Yeah, you can really place anything over NeoPutty. They did a study where they looked at what you put over MTA, whether that is like ZOE or Tempid, or I usually use a high viscosity glass ionomer cement like GC Equiforte or Fuji 2LC, or I think a really nice product is IonoSeal. Comes in a little tube. If you're using ZOE and you're doing a resin cement, you're going to get decreased bonding. So just make sure if you're putting zinc oxide eugenol in there, or a product that has eugenol, that you're using pure glass ionomer cement like Keytac or Fuji One, or a similar product that doesn't have any resin modified product in it.
Okay, awesome. Oh, I have yeah, a couple more coming through now. Great. I love the idea of the buildups. What are your thoughts on using cement as a buildup rather than a separate one? Do you see fewer crown debonds with that technique?
Oh, this is a good question. So, and I have a picture. I should have put it in here. Whoever you are, email me, and I can send you. But so my thought is, so if you're using something like, if you're using a glass ionomer cement like Keytac or Fuji One, it's a pure glass ionomer cement. That is going to rinse out a lot more readily than you doing either a double hit of Vitribond or some other medicament. Because if that crown comes off, if that kid, someone on iPedo just posted like the classic Jolly Rancher where the crown came off, then I still like it because that tooth is still well sealed. And I have a great picture. I'll have to add it next time I do this, because that's a really good question. But I like to put that on there because if this crown were to come off, then that cement comes off with it. Or when I've seen these teeth or the kids come in where the crown's off or have taken the crown off, a lot of times that cement, if it's a pure glass ionomer cement and there is moisture contamination under, it's slowly going to leach out because that kid's still high caries risk. So it's not an ideal seal. If you have a light polymerizing cement, like if you're using Biocem or using Fuji Evolve or something that light polymerizes, yeah, you can use that too. Polymerize it, then refine your prep, and then cement your crown on top of that. But yeah, I do find that if you do get a crown debonding, that tooth is just totally fine. Your pulp's totally fine. I actually have a picture where that happened. It was still super well sealed. And I just put a new crown on there. And it also makes my doing zirconia crowns or my restorative a lot faster because it just takes 2 seconds to add that medicament and then I have my walls back. So my retention and resistance form has been restored.
Awesome. Next question we have is, have you noticed any difference in results using NeoMTA and NeoPUTTY? I guess the difference between NeoMTA 2 and NeoPUTTY.
Oh, no. So it's kind of a through line of products as far as, and there's actually a really cool webinar by the woman who designed it. If you go on one thing that I do want to highlight, this person brought up a great question, is if people are switching from like ferric sulfate or formicrosol to any like NeoPutty or MTA like product, when I did formicrosol, you can put formicrosol on anything, and it's a slow death. That kid's gonna come back, and eventually that tooth will fail if it was too hyperemic. So these have a tighter window of diagnosis where if it really is an irreversible pulpitis, the tooth is going to bleed a lot, just like I showed you in that video. So that's why I don't recommend using ferric sulfate or things like that. But when people post on iPedo like, hey, have you guys used, NeoPutty, Smart MTA, any of the products? Yeah, I'm noticing a lot of failures. I'm always on iPedo, which is I guess I have too much free time. But it's interesting to see those, and what I think it's that the window versus a form of creosote pulpotomy is a lot tighter because our diagnosis has to be more improved. Because these do tend to do really well, especially in permanent molar pulpotomies. And I just like having that one product that's going to work and stick around. Versus formicrosol, it was great, and I used it a ton. But then you see those teeth that come back and they're resorbed, or you're taking them out, and so on and so forth. But it's probably just one, when you use formicrosol, there is a layer of inflammation, and two, maybe my diagnosis is wrong because formicrosol, if that's making sense. But no, yeah, with a through line with NeoMTA, NeoMTDA, and NeoPutty, it's all very successful. It's a very similar product.
Okay. All right, I'm gonna give it about another 30 seconds or so. Looks like we don't have any more questions, but if anyone else, like I said, we'll wrap up right at 8, another minute or so. But um,
Feel free to shoot me an email if you think
yeah,
about something later or have. I was at AAPD and we talked about apexogenesis and some people emailed some good questions. So
okay,
I was going to put my contact on.
there you go. Perfect.
Yeah, that's a bummer, Preston. Sorry. I was like, man, where did Preston go? And you were like, my
Yes.
internet's not working. And I was like,
Oh man,
oh, man.
panic and like, oh, it was super bad panic. Yeah. So, well, can you compare Theracal LC and I guess Neoliner LC or
Oh, yeah, I can.
yeah? Go ahead.
Yeah, so when you think about, and I'm gonna just quickly go to that slide. So when you think about Theracal LC and Neoliner, um, they're both calcium silicate materials. So what's really going to differentiate them is one, the degree, the physical properties, and then also the chemical properties. You're again, when we talked about earlier in the lecture, the degree of calcium release is highly important. And then also, again, if you're putting composite on it, or if you're using it in permanent restorations, it's flexural and compressive strength. Just kind of we talked about the water absorption and water solubility, and and your ability to build a quality restoration on top of that. So the neoliner does have a higher degree of calcium release, which is important over time as we place that restoration. And we're trying to, if we're using it as a base liner or an indirect pulp cap, and that degree of calcium release is going to be proportional to our ability to make tertiary dentin. So it's just you're getting the better chemical properties that are closer to an MTA that's not as adulterated with resin.
Okay,
So similar base material, but better chemical properties in the neoliner.
okay, great. Awesome. Well, with that, we'll wrap it up with there. And like I said, y'all, if you have any further questions, feel free to reach out to Dr. Ruck or myself, and I'll get the questions to Dr. Ruck. Remember, look for that survey from the events team, and that way we can get your CE. But thanks everyone for tuning in tonight. Like I said, reach out to us for next Wednesday for our Mastering Zirconia webinar. And if you have any other questions, just let us know. Have a great evening, everyone.